All right. Good morning, ladies and gentlemen. My name is Eric Yen. I'm the Director of Marketing for Shield Healthcare. Welcome to the webinar, Preventing Catheter-Associated Urinary Tract Infections. Your presenter today is Mary W. Sears with Capital Nursing. Listeners will be in a listen-only mode. If you have a question, please type it on the chat box to the right-hand side of your screen. Attendees are eligible for 1 CE contact hour through Capital Nursing. So after the webinar, please log on to www.capitalnursingeducation.com, and we'll provide that information at the end of the webinar as well. At this time, I'd like to introduce you to Mary Sears. Mary is a graduate of the Kosler School of ET Nursing at the University of Southern California in 1978. Mary has earned well-deserved recognition for her expertise, including the Pacific Coast Region Wound Ostomy Continence Nurses Society ET Nurse of the Year, President's Award for Excellence, and Mentor of the Year. Mary served as wound care specialist and clinical resource specialist for Kendall Covidian and Convatec, respectively. She is currently a clinical consultant with Capital Nursing Education, sharing seasoned skills and expertise with the healthcare community. At this time, I'd like to pass the presentation over to Mary Sears. Mary.
Thank you, Eric. Good morning, everyone, and thank you for joining us today. We're going to be looking at a very serious subject today, and it is catheter-associated urinary tract infections. Some of this, for you that have been nurses for many years, may be a repeat, but because this is a critical thing by the CDC now, as well as Medicare and Medi-Cal, we really need to take a look and refresh some of our information about this. We have two objectives today, really to look at the advantages of intermittent catheterization over indwelling catheterization, and to look at some of the clinical conditions that are considered acceptable for the placement of indwelling urinary catheters. As with this area, as so many others, there are best practice outlines out there, and two that I'd like to refer you to are by the Wound Ostomy Continence Nurses Society, Indwelling Urinary Catheters, Best Practice for Clinicians, and Suprapubic Catheters, Best Practice for Clinicians. Both of these standards can be ordered through the WOCN bookstore at WOCN.org. Just a review, urinary catheterization, we know, should only be undertaken when all other methods of urinary management have been deemed inappropriate, have been deemed appropriate, or have failed. And urinary catheters are frequently placed both for short-term and long-term urinary problems. Indwelling catheters include the urethral, which most of us are very familiar with, and the suprapubic, and we're also going to cover intermittent catheterization today as well. Suprapubic catheters are inserted surgically through the anterior abdomen and approximately 2 centimeters above the pubic bone into the bladder. And this does allow for continuous drainage of urine, as does the indwelling Foley catheter. Indications for suprapubic catheterizations are usually for short-term, usually following surgery. It's an alternative to the chronic indwelling Foley catheter. It can be used for long-term catheterization if needed, and many times this is preferred in the male because it helps prevent urethral damage caused by an indwelling Foley catheter. The advantages.
I'm sorry to interrupt you. There's some questions regarding the volume. If you could speak up a little bit and into your mic, that would be really great.
Sure. We will take care of that right away. All right, is this better?
Yes, thank you so much.
You're very welcome. The advantages of suprapubic catheters really is that they decrease the risk of contamination from organisms from fecal material and increase the necessity to look at other areas such as cleansing of the perineum and that kind of thing. With suprapubic catheters, because it's not located close to the rectal area, the contamination is much less than it is with the Foley catheters. But people with suprapubic catheters can have potential problems, just as those with indwelling Foley catheters. Urine leakage around the sites, then skin erosion, and sometimes there will be presence of a hematoma following insertion. So all of those things are issues that need to be dealt with by staff. The insertion and reinsertion, let's talk about that for a few minutes, the suprapubic catheters. The original insertion is done by a physician or by a specially trained urology specialist. The new suprapubic tract takes approximately 10 days to 4 weeks to become established. And if anything happens that the catheter would become dislodged during that period of time, it makes reinsertion more difficult. The reinsertion can be done by a trained healthcare professional after the tract is well established, and frequently patients themselves will even be taught to reinsert the catheter after the tract is well established. This causes some apprehension in patients and is really important that we work with them and include this in teaching prior to the time that they're discharged to really cut down on that apprehension. Routine care of the suprapubic catheter. Frequently, patients will not even wear a dressing around the site. It's not required. If they do, it's usually because they feel that it's a little bit more comfortable to have a dressing around the site. The catheter should always be secured to the lower abdomen to prevent any erosion of the tract itself. And these patients frequently will need to go through cystoscopies annually and ultrasounds just to look for any risk of stones or any squamous cell carcinoma that might originate at the site. The collection of urine from a suprapubic catheter is very much the same as an indwelling Foley catheter. It may be connected to a drainage bag, or it may be connected to a leg bag, and using an adapter and a strap, it immobilizes the catheter so that there's not erosion around the tract. The removal of the suprapubic catheter is fairly easy. Gently rotate the catheter to release any ingrowth around the catheter site. Deflate the catheter balloon, and then make sure to hold the catheter at the point close to where the insertion goes into the abdomen, and keep your fingers at that point so as you withdraw, you know the distance from where it went into the abdomen to the end of the tube. It's a good idea to clamp the suprapubic catheter prior to removal and let a volume of urine accumulate in the bladder, because then when the new catheter is inserted, you don't have to wait for the urine to accumulate. You immediately know that you're in the bladder. Permanently, if the suprapubic catheter is no longer needed, then the area can be covered with a dry gauze and will heal within a few days following removal. When do people really need to call for help with any type of catheter? It's really important if the catheter is blocked. Of course, urine will not accumulate in the bag, so looking for any kinks in the tubing or that kind of thing are critical. If the catheter leaks, of course, you have to worry about the skin around the catheter site, or whether that is in the urethra or if that's suprapubic. Pain in the back just below the rib cage or flank pain can show that there is a problem going on and there may be an infection present. Certainly fever, chills, or body aches, or any groin or belly pain. If the urine is cloudy, and remember that there are some foods that we eat that will make the urine odorous, so odor is not always a good thing. If the patients have had asparagus or something of that sort that's going to make the urine have an odor, certainly they want to be aware of that. Pain, increasing redness or bleeding at the catheter site, or swelling around the catheter can all be indicative of problems. Indwelling Foley catheters, we need to remember, are not an acceptable clinical practice unless their specific clinical conditions exist. And these are very well outlined by the CDC. Catheters tend to become colonized in 30 days, and 30% of the patients will develop a urinary tract infection. What are the indications, according to the CDC, then, for indwelling urinary catheters? And these are the things that, as we assess our patient and evaluate that they have a catheter, we need to know if any of these things were present, because these would be a good indication for an indwelling catheter. An acute urinary retention or obstruction. If our patients are in the intensive care unit, then of course accurate measurement of urinary output is really necessary. If the patient's immobile because of trauma or because of surgery and unable to get to the bathroom or otherwise do any other type of catheterization, then it might be need for one. Stage 3 or stage 4 pressure ulcers, either of the sacrum or in the perineum. Many times patients will have an indwelling Foley catheter while those wounds heal, so that they're not incontinent and the wounds are not contaminated by urine. Inability to void due to neurologic bladder is also an indication. And many times if patients are on hospice or palliative care, it's more comfortable for them to have a Foley catheter to deal with urinary incontinence than to be moving them and repositioning them, which can be very, very uncomfortable. Inappropriate uses of indwelling urinary catheters, we never want to insert a Foley just to obtain a urine culture. Are not as a substitute for care of incontinent patients. There are many other things that we can do to assist those patients who have incontinent issues rather than just placing a Foley catheter. If there are long postoperative periods where the patients are going to be unable to mobilize themselves to the bathroom or whatever, then that would be an appropriate use. Remember that if patients require catheterization, intermittent catheters should be considered first, and indwelling catheters should be left in place as short a time as possible. And this is directly from the Centers for Disease Control and their advisory committee in 2009. So let's talk about catheter-associated urinary tract infections now. And I will refer to this throughout the presentation as CAUTI because it's just so much easier to do that. We know that hospital-acquired infections affect 1 out of every 20 patients. And according to the Institute for HealthCare Improvement in 2011, 80% of those hospital-acquired infections were attributed to an indwelling urinary catheter. 12 to 16% of adult patients will have urinary catheters during a hospitalization, and the prevalence in hospital rates for CAUTI can be as high as 25 to 35%. Dr. Michael Gray from our organization estimates that 67 to 76% of adults in the intensive care unit perhaps will have CAUTI. The rates are examined as part of CMS Hospital-Acquired Condition Reduction Program. And this means that if a hospital has a high rate of CAUTI as well as other healthcare acquired infections, it can face a 1% reduction in Medicare payments as part of the program. This is one of the most frequently rates that has not improved over the ages. and over the last several decades. The CDC last year showed a 6% increase in CAUTI since 2009. So the rates are not coming down. In fact, the rates are on the rise. These following figures are from the American Nurses Association's initiative to reduce CAUTI. This is a program that the ANA put in place in 2015. We know that CAUTI is the most commonly reported healthcare acquired infection. More than 560,000 patients develop this each year. 70% of these catheter-associated urinary tract infections are preventable. And that's the reason that the ANA feels that as 3.4 million nurses work with patients, that they can really make a difference in this area, as they have in the area of surgical site infections. So they have launched this campaign to really get nurses more involved in being able to identify when patients have a catheter-associated urinary tract infection and be able to intervene to decrease those numbers. 5 million catheters are inserted each year in the United States. What is amazing is that 50% of these patients do not meet the CDC indications for the catheter, or putting a Foley catheter in. Those are the things that we referred to earlier. The Institute for Healthcare Improvement in 2011 reported that 40% of physicians are not even aware that their patients have a catheter. Patients with a urinary catheter are at an increased daily rate cumulatively of 3 to 7% of developing urinary tract infections. And we know that the mortality and length of stay is increased if this develops. Annually, this may contribute to 90,000 more hospital days, and in dollars, that means between $4 and $5 million to the United States healthcare costs. Home care, approximately 8% of those patients will develop a urinary infection. This is the most common infection in long-term residents in our skilled nursing facilities, and we know that we need to look at patients that are admitted into the skilled nursing facility all the time if there is a catheter in place to make sure that there is an indicated need for that catheter. In 2008, CMS identified hospital-acquired CAUTIs as one of the 8 conditions for which hospitals will not receive additional reimbursement. So this can make a tremendous difference in the bottom line. For those of you who may work in long-term care, I'm sure that you are well aware of FTAG 315 or Federal Tag F315. If not, you can look at that on cms.gov. It really shows several aspects that are considered in the long-term care, 3 particularly. It says that a resident who does not have an indwelling catheter does not have one inserted unless the clinical condition warrants it. The facility provides appropriate treatment and services to prevent urinary tract infections, and that the facility attempts to assist the resident to restore as much normal bladder function as possible. What are the symptoms of a urinary tract infection according to the Association for Professionals in Infection Control, or APIC? These are their criteria for identifying a urinary tract infection, and we know that pain on urination, frequency, urgency, all are signs that we need to be aware of in our residents and in our patients. A fever over 104 degrees and a difference in the character or the color of the urine oftentimes will point out that there can be problems in this area. Beware, though, that older patients with indwelling Foley catheters may not present with the typical signs and symptoms of infection. So in our elderly, any change in mental status, particularly if they're in the skilled nursing facility or if they have dementia or Alzheimer's and are unable to point things out to us that may be changing. Any subtle changes could be indicative of a CAUTI. To diagnose a CAUTI, it's important to obtain a urine sample from a freshly inserted catheter or collection port of an indwelling Foley catheter. Never take the urine from a leg bag or from a urinary drainage bag for a specimen. And then to perform a dipstick for urinalysis. And diagnosis of CAUTI is only made when the signs and symptoms of CAUTI coexist with the positive urine culture and with increased white blood cells in the urinalysis. Indwelling Foley catheter, place it only when it's necessary and remove it as quickly as possible. That is really the bottom line. It needs to be inserted by a trained person using sterile technique, making sure to clean the skin around the area where the catheter is to be inserted. 18 French or larger catheters are not ever recommended because it causes erosion of the bladder neck, and the urethral mucosa actually forms strictures and impedes the drainage of the periurethral gland secretion. So we don't want to use real large catheters. 30 millimeter balloons are not recommended either. And we want to try to always consider other methods to drain the urine, external catheters in men or intermittent catheterizations, which we're going to cover in this program. Indwelling urinary catheters, according to the ANA in this prevention packet that they have delivered, these are the things that they point out as being critical. First of all, prior to insertion, make sure that the CDC guidelines that we talked about earlier are met, and those are the things that we covered in slide 13. Select the smallest appropriate catheter, usually a 14 or a 16 French with a 5 or 10 cc balloon. It's important in today's world, we're dealing with many patients that are larger patients. It's more difficult to do things just alone, one nurse. So please be aware that if you need assistance to really get the legs apart and expose the labia and be able to do this sterilely and without contaminating the catheter, we may need to get additional people to help. Performing hand hygiene is always very, very important. How do we prepare the patient? Of course, we want to do very meticulous peri-care before we start. Make sure that our hand hygiene is complete and that we've washed and gloved appropriately. And we want to re-perform hand hygiene upon completion. Insert the catheter to the appropriate length and check the urine flow before the balloon is inflated, and then to inflate the balloon correctly to 5 or 10 cc. After the catheter is inserted, then it's important to stabilize the urinary catheter and the drainage system, securing the catheter so that it does not move back and forth through the urethra and cause irritation. Position the drainage bag below the bladder but not on the floor, and to check the system for any closed connections and make sure that there are no obstructions or links. Catheter care. Hand washing is so important by the caregiver. We know that we need to always use closed drainage systems and secure the catheter to the legs so that it does not cause irritation of the urethra, making sure that it's not kinked or twisted, to keep the drainage bag lower than the catheter. And important to really do something so simple as making sure that we empty the drainage bag frequently. You know, when you see a drainage bag hanging on the side of a bed of a patient that's being diuresed with 1,000 cc's in it, that's going to impede the flow of urine into that drainage bag. And it's always important when we're working with patients, if they're going to be discharged home or to another level of care with their catheter, to make sure that we do some education with the patient so that they know what is necessary. Additional teaching considerations, it's recommended that cotton underwear be worn. Patients need to stay hydrated, drinking 4 or 8 glasses daily of water to keep the urine a pale yellow. We don't want urine that is rust-colored or dark yellow. Avoiding any bladder irritants, which are caffeine, colas, alcoholic beverages, and avoiding constipation. And this is most easily done by increasing the fiber and making sure that along with that fiber, we're giving patients adequate fluid intake. Reporting to the healthcare provider any of these signs is very important, and we've already covered this somewhat. Some of the common problems that can occur are accidental dislodgement, so we need to know what to tell our patients if that should occur and to call their healthcare provider. Any leakage of urine around the catheter, if there's no urine in the bag or the color and odor changes, or there are bladder spasms, all of those things should be reported to the healthcare provider. Urinary catheterization assessments, it is important to always look at, is this patient still a candidate for a urinary catheter? Do they still have those criteria that we evaluated in the first place by the CDC, making it possible for them to continue their catheter usage a little bit longer? Is the catheter functioning properly? Looking at the output as it compares to their intake. If they've got very little output and they're drinking a lot or they're getting a lot of IV fluids, there's probably a mechanical problem there someplace. We've talked about stabilizing the catheter, making sure that there will not be excoriation around the urethra orifice, or if there's any leakage of the catheter. Now let's talk a little bit about intermittent catheterization, because this truly is the safest bladder management to prevent upper and lower urinary tract complications. So things such as hydronephrosis, renal calculi, bladder calculi, any backward flow of urine into the kidneys, these can all be potential problems. And these are safer and will not occur so much with intermittent catheterization. So intermittent catheterization is really becoming the gold standard for bladder emptying. And this is where a catheter is inserted for a brief period of time into the bladder to drain urine at regular intervals. And then as soon as the urine is drained, the catheter is removed. The advantages of this are thought to be that there is less risk for CAUTI because the catheter is not in place for a long period of time. It minimizes the episodes of overdistension of the bladder, but this is only so if the patient is catheterizing on a schedule. Sometimes patients that independently do intermittent catheterization will stretch the time between their cathing episodes out to like 6 hours or 7 hours. They're busy, they get caught up in other things, and they forget that they really need to go empty their bladder. And then that can put them at increased risk for bladder infections. The advantages of intermittent catheterization over indwelling urinary catheterization is it really promotes self-care and independence. Patients once they've learned to do it, really like to do it because they think that it makes them feel more independent. There's an increased risk of catheter-associated complications with this. They need less equipment such as drainage bags, night drainage bags, leg bags. It's less barrier to intimacy and sexual activities if patients are sexually active. Potential for reduced urinary tract symptoms such as frequency, urgency between catheterizations. This is really the best way to go if at all possible. In the non-acute setting, patients may use clean technique and not sterile technique for intermittent catheterization. With that being said, I want to stress still that cleaning of the perineum and hand washing is imperative. It doesn't have to be sterile, but really you need to observe your patients when they are learning to do this and teach them that hand washing is very, very important. The bladder volume should never exceed more than 400 cc. So if you have patients that aren't cathing every 4 hours and it gets up to where they've got 600 cc's out, that's a lot of residual or a lot of urine in the bladder that can cause problems. We want to consider hydrophilic catheters, those that are lubricated whenever possible. It is easier on the urethra, and it really makes it more comfortable for the patient. We recommend single-use catheters. Clinicians should remember always to follow the manufacturer's instructions for whatever catheter they're using, and they should be provided with an adequate number of catheters to allow the use of a single catheter for each catheterization. It's important as clinicians that we inform patients, family members, and caregivers that catheters are for single use only. And even though CMS has not made a recommendation at this point on this, in the spring of 2008, they increased the monthly catheter utilization up to 200 catheters a month. Intermittent catheterization techniques, you may hear them referred to as clean intermittent self-catheterization or intermittent self-catheterization. All of those are terms that are kind of used with each other. Intermittent self-catheterization candidates, we need to make sure that the ideal candidate has an unobstructed urethra, good vision, good perineal hygiene. That's so important, and particularly in our elderly patients, because a number of elderly patients will be incontinent of stool and maybe also incontinent of urine. So good perineal hygiene is imperative. Motivated and compliant is really important, and if patients need assistance, sometimes a caregiver needs to be taught to help them with this because they may be unable to perform it by themselves independently. We've talked a little bit about the obese patient or the patient with large abdominal girth. Women who have abductor spasms and are unable to separate their thighs, they're going to have a very difficult time doing intermittent catheterization. What are the barriers to intermittent self-catheterization? One of the largest ones in the beginning is fear, because patients are really afraid to do this. As nurses, we get used to doing some rather complex things and take it pretty matter-of-factly, but when the patient is doing these things on themselves, that is a different story. Age should not be a barrier. In my clinical practice, the youngest patient I ever taught to do intermittent catheterization was a little girl, 4 years old, and she did a tremendous job. She had a lot of support from her mother, but she was able to learn to do this very, very effectively. any spasms of the leg or decreased flexibility or balance, decreased hand figure dexterity, any tremors of the arms or the hands. It can make it difficult for patients to do this. And as I said, children may exhibit anger, frustration, noncompliance. They may need close adult supervision to learn to do this. So when we're teaching it, we need to identify someone who can assist the patient, especially in the beginning. That person needs to be available several times a day for an extended period of time in the beginning. And as I've already indicated, attention to the patient's personal hygiene is so important. The patients must wash their hands. They must clean the genitalia because many female patients, even though this is something as nurses that we kind of take for granted, and we teach patients to always, female patients, always to wipe from the front to the back, I can tell you that does not happen that frequently. So it's really important to watch the patient as they're doing this and really try to give them some direction as to the proper way to do it. Good hygiene is important to avoid urinary tract infections and certainly to teach people the signs and symptoms of a UTI before they're discharged. Positions for self-catheterization, women usually do this lying on a bed in a semi-sitting position or sitting on the toilet and leaning back. They may squat or stand over the toilet. That's done sometimes as well. Standing with one leg on the toilet or the bathtub. And we teach women to do this by touch because mirrors are really cumbersome to use many times. And so once again, you see the necessity for careful hand washing. It's important too to realize that women may have some difficulties doing this, and if they're trying to use a mirror as well, that is just going to impede the process a lot. Men usually sit on the toilet or stand in front of the toilet to do this, and it's important for them to hold the penis in an upright position to straighten out the S shape that occurs. Catheterization schedule, general rule not to exceed 400 cc's in the bladder. And I'd like to point out here too that when patients are doing intermittent catheterization, sometimes the way the catheter comes out of the urethra, in other words, if it tips upward slightly, the urine is not going to drain out as well. And sometimes the patients, in an effort to see if urine's still coming out, will tip the catheter up, which makes the urine stop flowing. So they think that the bladder is empty. They remove the catheter when indeed they may have another 150, 200 cc's of urine in the catheter that is not drained out. The catheters are fairly small, so it doesn't drain out real quickly. So it's really important to instruct your patient to try to tip the catheter downward toward the water in the toilet if they're sitting on the toilet, and to really watch and make sure that the urine is not draining out before they remove the catheter, because we don't want them to wind up with residual of several hundred cc's in the bladder and they think that they've emptied the bladder well. Catheterize before going to sleep and upon awakening. And the morning catheterization will probably be catheterized urine volume. Eric, can you still hear me?
Yeah, you're doing great. Thank you.
Okay, thank you very much. We're just having to switch phones here for a minute.
Okay.
Let's talk a little bit about living with a catheter, because it takes a period of time for patients to get used to living with a catheter. And that's even estimated to be as long as 1 year. Patients may experience many worries and fears during that period of time. They're afraid the catheter is going to fall out if it's a Foley catheter or a suprapubic catheter. They're concerned about odor of urine, and keep in mind that many times these patients may have been patients who are now doing intermittent catheterization because they were incontinent, and so they're very aware of that smell of urine. They don't want to be wet in public. It's important that to them that the catheter and the drainage bag aren't visible to people if they go out to the market or if they go shopping. There's a lot of inability to express feelings about the catheter because of the placement of where it is, difficulties with sexual expression. All of these things really make it difficult for patients sometimes to adjust to the catheter. We're going to talk just a minute about urinary tract infections and a catheter that is fairly new to the marketplace in the grand scheme of things. These catheters have what is called an introducer tip on it. And if you look at this slide, excuse me just a minute while I get a drink of water. You will see a plain area that has an opening on the end, and then the catheter is pushed through that area. So Dr. Newman, Dr. Diane Newman, who has worked in this area for many, many years, maintains that even with very, very careful cleansing, the first 2 centimeters of the urethra is heavily contaminated, even when we do a real good job of cleansing. So with this catheter, the catheter can be inserted. It is pushed up next to the urethra to where you see the cuff part, and then at that point, the catheter is advanced through the introducer tip into the bladder. And it's really thought that these are doing some very nice things to help avoid urinary tract infections. There are many different kinds of intermittent catheterizations. The sizes that are available are similar to those for indwelling catheters. The diameter is measured in French units, just as it is with Foley catheters, and they range from 6 to 12 French for children and from 14 to 22 French for adults. There are many different kinds of tips, as you see in the top middle slide. There are straight catheters. There are coude catheters for areas that are more difficult to catheterize. If you look at the bottom pictures, you will see that some of them are very, very small. These catheters have different lengths and they're gender specific. Some of them come with disposal bags already attached to them, like the one with the introducer tip that you see on the left there. And some of them are very, very small and can discreetly be carried in a pocket or in a handbag for use when needed. What do we really look at as we're educating people about what needs to occur with intermittent catheterization? Certainly proper catheter insertion and care, and we need to try to talk to people about what the problem solves. If there's no urine in the bag, well, most usually that's because of a mechanical problem. So look for any kinks in the tubing or obstructions in the tubing. Leakage, if there's leakage around either suprapubic site or a Foley catheter site, of course that's going to set the patient up for skin management issues, just the very same as other types of urinary incontinence would. So we really need to work with patients to know what kinds of things to refer to their healthcare provider, and try to instruct them on any additional information that they will need to be able to be successful at this. Together, I know that we can all strive to provide the best possible outcomes for the catheterized patient, so that they will be free of infection, so that they will have a quality of life that they would not have if they were incontinent or leaking urine. At this point, Eric, I'd like to turn this over to you to talk with them about the hydrophilic catheter in the bag.
Great. Thank you, Mary. That was a great presentation. If you have a question for Mary, please type it on the question box to the right-hand side of your screen. And as we're waiting for questions, I'd like to talk about our new hydrophilic cath and bag. The JAW stands for Just Add Water. So it's exclusively distributed through Shield, and it's a cath and bag designed for touch-free insertion to reduce the risk of UTI. So we talked a lot about CAUTI, and the JAW is a good solution for reducing UTIs. It's got a hydrophilic coating. It's got the water sachet that you actually burst, and then it activates the coating. And what's unique about this, it's a cath and bag system, but it's billed as an intermittent catheter. So for those of you familiar with the billing, cath kits can be extremely difficult for patients to get because Medicare requires a lot of documentation from your physician. It requires at least 2 to 3 UTIs, documentation of the UTIs for a full year. So the JAW actually reduces the number of office visits for your patients, and it does have the cath and bag and the bag component with it. So those who are listening are qualified for 30 free samples. So if you log on to www.shieldhealthcare.com/JAW and put your information on there, we will send you 30 JAW samples for you guys to try, for your patients to try. So again, it's a cath and bag that's billed as an intermittent catheter, so it's really, really unique. So I encourage you to check that out. So Mary, we've got a bunch of questions here, which is great. So first off, can we get a copy of slides? Yes, we'll post these slides on our community site after the webinar. So you can check out www.shieldhealthcare.com/community. And we'll have the recording and we'll have the PowerPoints up for you to peruse. So a question here, Mary, to obtain a urine culture, would you recommend the straight cath kits that come with small catheter size?
Just to obtain a urine culture, yes, that would be a very good choice.
Great.
Remember one thing that I did not point out, we did talk a little bit about how to obtain the specimen, but just as important as obtaining a good sterile specimen is the importance of getting it to the lab quickly after the specimen is drawn. I can't tell you the number of times that I've gone into the nurse's station maybe 20, 30 minutes after they've catheterized the patient, and the specimen is still sitting in the nurse's station. And then all the bacteria begin growing, and you don't have a specimen that really is reliable. So try to get it to the lab as quickly as possible.
Great, thank you, Mary. Can you clarify one thing? You had a slide that showed the temperature greater than 104. Should this be 100.4 for CAUTI symptoms?
No, it is 104,
okay.
But most of the time patients will feel, they may be feeling not well long before the temperature gets to that degree, but
okay.
That is what is published in the literature.
Okay, so you talked about catheters leaking. What can be done if there's leaking around the catheter?
You know, this is something that has been confusing for nurses for many, many years. I remember long before I ever became a woundostomy continence nurse, working as a staff nurse, the thing that frequently was done if a catheter was leaking is that the catheter was removed and a larger catheter was put in, or a catheter with a larger balloon. What we need to recognize is that frequently the reason the catheter is leaking, it is because of inflammation. It urethra or in the bladder. And so the WOCN has some very, very nice information on that first document that I spoke about, the best practices for indwelling Foley catheters, that looks at inflammation and looks at all of the other causes that can impact and result in leakage around the catheter. So I would really encourage people to get those documents and really look at them, because it can be everything from medications to constipation, a number of things that cause inflammation at the site and therefore the catheter to leak. So we don't want to just go to inserting a bigger catheter with a bigger balloon. We need to be looking at what the cause of the inflammation is and addressing that.
Great, thanks, Mary. Can you give a more specific situation in which you would use a CAUTI tipped catheter?
Yes, CAUTI tipped catheters most frequently are used for difficult to catheterize patients. If you are trying to catheterize a patient with a regular catheter or a straight tip catheter, and you are having problems getting that catheter through the urethra into the bladder, then that is when you're going to want to consider a well-lubricated CAUTI tip catheter. Because of the curve at the end, it makes it a little bit easier, especially if you turn it a little bit in your finger as the catheter, as you're trying to insert it. Then, because the tip is curved, it will more easily go through the urethra into the bladder.
Great, thank you, Mary. What are your thoughts about flushing and irrigation of the Foley catheter? Should we encourage this practice?
Well, I'll tell you, I'm not sure what all of the very recent information along those lines says. Here's what I would say to you. The reason most usually that we flush a catheter is because it is not draining properly. And when any time you irrigate or flush a catheter, you have to realize that you are interrupting that closed drainage system that you're trying to keep in place, even with the additional ports on catheters. So I would first of all look at when was that catheter inserted, how long has it been in place, because incrustations do grow and biofilms do grow on the inside of these catheters, and of course that will impede the output. So probably what needs to happen, rather than flushing or irrigating the catheter, as long as you're sure that there are no kinks or obstructions in the tubing that you can see as a result of the patient lying on it or something of that sort, most usually you need to take the catheter out and insert a clean Foley catheter.
Great. Now, how often does an indwelling catheter need to be changed?
Most institutions want to change it every 7 to 14 days.
Okay, great. And what are your thoughts about wearing external condom catheters between intermittent catheterization? Is this an acceptable practice?
Yes. In certain circumstances, for instance, if the patient has a neurogenic bladder or something and they are going to be incontinent of urine in between the times that they are capping, then certainly for them to wear a condom catheter is far preferable to having urine leakage all over the place and maceration of the surrounding skin. So yes, that would be very much preferred to just having uncontrolled incontinence. However, with that being said, there are also many other types of ways that incontinence issues can be dealt with these days. such as Botox injections of the bladder and that type of thing that might help with that. So I would certainly encourage, if you have a patient like that, I would certainly encourage them to talk to their urologist, let them know that they continue to be incontinent of urine in between doing their intermittent catheterization, and are there any other management principles that might be used with them until that issue can be resolved. But yes, a condom catheter is certainly preferable to urinary leakage and wet clothing all the time and that type of thing.
Great, thank you. There's so many questions here. We've got about 3 minutes, so we can only do a couple more, and I apologize for that. What frequency of pericare should be done on a member with an indwelling catheter to prevent UTIs?
That is dependent on many things. First of all, we want to try to keep the area around the insertion of the indwelling Foley catheter as clean as possible. So certainly we want to do that. So many things have changed in nursing these days. Patients frequently do not get baths anymore, bed baths when they're immobile. That used to be a standard of care that was exercised every time you gave a patient a bed bath, which was daily. Well, all of us know that doesn't occur anymore. So I think to try to keep the area around the catheter as clean as possible. If you notice that there is increased secretion around the catheter, now I don't mean urine, but I mean mucus or any kind of secretions around where the catheter enters the urethra, then certainly you want to clean that. If you have a patient who has incontinence of stool, that is the main thing, then that patient is going to need more frequent pericare than a patient who is not incontinent of stool. So that depends on circumstances a lot.
Great. Thank you, Mary. Again, I apologize. We only have time for a couple more questions. Mary, when you say the catheter should be fresh for obtaining urine sample for culture, how many days is a catheter considered to be fresh?
Oh, my goodness. The thing is, any time a catheter has been in place, any period of time, the chance of there being contamination of that catheter and around that site is pretty high. I think that the important thing to look at is everything else that is impacting what's going on with that patient right now. If this is absolutely a critical, we must have as reliable a sample as we can get, such as like in the intensive care unit or that kind of thing, then they probably are going to need to replace the catheter and take a urine sample when the new catheter is inserted.
Great. Thank you, Mary. All right, there's a couple questions on the jaw. The jaw is covered by Medicare. Medicare allows, I believe, $150 per month for your patients, with, and there's no documentation of UTIs necessary. So it is not covered by Medi-Cal as of yet. We're still waiting to get on the Medi-Cal formulary. But Medicare patients, the jaw is covered. So, someone asked about the website again. It's www.shieldhealthcare.com/jaw, and that stands for Just Add Water. So I encourage you to go on there. Mary, thank you so much for that great presentation. I apologize to the viewers who we were not able to answer all your questions. If you do have additional questions, you can contact Capital Nursing, and the website or the email is on your screen, capitalnursingeducation@gmail.com. You can also email us at marketing@shieldhealthcare.com. So again, if you do want to receive one CE contact hour, please visit capitalnursingeducation.com and click on the Register tab to complete the form. I'd like to thank everybody who attended the webinar. I'd like to thank Mary for that really, really informative presentation. So tune in December 8th. We've got another webinar identifying pressure ulcers. So stay tuned for that. Again, thank you very much for attending. If you need more information, you can go onto our community site, www.shieldhealthcare.com/community. And thank you very much. Have a great afternoon, everyone.